to just give it a moment while we continue to let folks into the session. We have a few folks still kind of trickling in. Okay, well, I see the attendees kind of slowing down a little bit, so we'll get started. Good afternoon, and thank you for joining us for the monthly opioid response seminar. I'm very excited to be joining you today. My name is Brianne Maselli, and I'm the Mental Health Division Manager at Office of Behavioral Health. In my role, I oversee our community mental health programming as well as our crisis services, and I'm very excited to be joining you today. Today's session will focus on some of our great efforts underway as we are advancing our crisis work. Throughout the past 2 years, we've been advancing through crisis reform work, looking at increasing our capacity to advance alternatives to crisis support. We're looking to make sure that we have a trauma-informed access for individuals in needs at multiple levels within the system. Crisis receiving centers are part of that continuum, and Maine has aligned with national best practices, identifying someone to call, someone to respond, and a place to go. We have invested over $15 million in our crisis reform efforts to date and are very excited to be able to have an opportunity to speak with you today about the innovative work related to our crisis receiving center that Spurwink is currently operating in Cumberland County. So Ben, if you'd like to share the slide deck, we'll jump right in.
Sure. So my name is Ben Strick. I'm the Vice President of Adult Behavioral Health for Spurwink Services. And we oversee the state's first crisis receiving center, the Living Room Crisis Center in Portland, Maine. Bree, are you able to see that? Terrific. I think that you are muted.
Yes, sorry, apologies. I just got moved out of the Zoom meeting. So we'll jump right in. Ben, you could move to the next slide. So as I mentioned earlier, SAMHSA has identified national best practices in regards to advancing crisis reform efforts. So they are utilizing the framework of someone to call, someone to respond, and somewhere to go. So as you can see here in the graphic, someone to call is our main crisis line and our 988 efforts nationally. We do have peer support lines as well as our Wabanaki Care line, creating multiple peer-run and formal opportunities for folks to reach out by phone. We also have our someone to respond, which is our mobile crisis response teams statewide. And each of those facilities has walk-in hours as well, so folks are able to receive some in-person support. But what we're really highlighting today is really looking at the somewhere to go, because this is new for us here in the state of Maine. We have had crisis residentials in every district for children and adults, but our Cumberland County Receiving Center that Spurwink is doing is really our innovative programming that's been added to the array in the last couple years. Next slide. So here's just an evidence-informed model that really looks at how we here in Maine are describing crisis receiving centers. Here in Maine, they are centers that provide immediate and short-term walk-in access to an array of both clinical and non-clinical mental health and substance use disorder crisis stabilization services. To all individuals, regardless of severity, and insurance coverage will be able to be seen and supported within these centers. Our model blends some of our national best practices that SAMHSA has identified, which is a crisis hub and a crisis center, which really serves as a walk-in immediate access to service. The crisis stabilization, where individuals are able to stay up to 23 to 72 hours with some medical monitored services, as well as our peer support element of living rooms, really which allows individuals to receive services from individuals with like experiences at a bit of a more supportive non-clinical approach. And what's nice is individuals could walk in to centers and select services that meet their need based on their self-identified crisis. And so I will turn it over to Ben to continue talking about his great work down in Cumberland County and hear more about what we've been learning through implementation. Ben, I'll turn it over to you.
Thanks, Bree. I think, one of the things I want to point out on this slide before we move on is that idea of comprehensive and co-occurring, that when people come in, crisis is self-defined. It is not something that we are saying, if you don't meet this definition, then we can't serve you here. It's really a no wrong door approach to providing behavioral health care, including walk-in induction for folks with opioid use disorder. So when we look at the population that we're currently serving, it's 24/7, 365 days a year. Monday through Friday, 9 to 5, we've got a nurse practitioner, a clinician, nurses, crisis service providers, and peers on staff. The rest of the time, we have crisis service providers and peers on staff overnights, but really that nurse practitioner is on call after that 9 to 5 Monday through Friday time frame. We serve folks ages 14 and above. Folks in that kind of 14, 15, 16 range, we can isolate by sight and sound. Above that, we have a large central living room area that we'll talk about, as well as multiple individual rooms. We provide immediate crisis intervention, assessment, and then as well as peer support, opportunities for observation, and then linkage to ongoing care. If there is not immediate linkage, we are able to provide short-term care for people in need in the community. Bree, do you want to add anything?
I think you hit on the core functions of the model.
Thank you. So this is our space. What you see down in the bottom kind of right-hand side is the door to come in. You walk in and there's an open horseshoe. Somebody will greet you and you'll be invited into the space. There are no medical detectors. You're not searched. You're not asked to give up your bags or change your clothes. It's really a very, very different approach than, say, going to the emergency department. In the middle, you see a central living room area. We often have folks that are hanging out, having coffee, talking with a peer in that area. Some folks that are experiencing a crisis feel more comfortable around other people. They don't want to be alone. And other people want to be in a room and have some privacy. So we wanted to be able to accommodate both. Around the outside, what you see are 8 individual mini living rooms, we call them. Each have at least a love seat and a chair. Some are much larger and have a couple of couches and a couple of chairs. The furniture is behavioral health safe, moisture, bedbug, and ligature resistant, but it's also very homey looking. So the goal was not to have a very industrial or institutional looking space, but to make it warm and inviting. The rooms are badge access to get in, but you can leave at any time. It means that if there's something going on in the space and you feel like you need to be locked away to feel safe, then we wanted to make sure that we could provide that for people. You see 3 bathrooms down along the bottom side, 2 with shower. And so a lot of the time folks are coming in, they might be cold, they might be hungry, they might need a change of clothes. We want to make sure that we can help address those immediate needs and then work on long-term planning after those immediate needs have been met. Any questions? Bree? This is the backside of the space. So on the backside of the space, you see a group room. So we provide follow-up groups that include things like hearing voices, an all recovery group. Because we are a mental health facility, we can't offer alternatives to suicide, but we have folks that are trained in that model and offer a similar group called Sharing the Darkness. We have LGBT specific groups. We have Maine family planning that will come in. We have multi-faith groups. So the idea is that folks can come back for ongoing connection as needed. We have a kitchenette area. We offer heavy snacks at all times. And so it's not a full cafeteria, but we have sandwiches, cereal, Easy Mac. Often there will be pastries, granola bars, Pop-Tarts, food, lots and lots of coffee. I joke that our coffee budget is larger than the Portland Recovery Center. We've got a med room that is well stocked with supplies for wound care. We see a number of folks with IV drug use acquired infections. And then we have a pharmacy in the space and are able to prescribe really as needed for people during that 9 to 5. And then we have limited ability overnight. The idea for us is to be able to provide those who are interested in initiating recovery ability to access Suboxone, Sublocade as needed. We also have laundry facilities. And then the area kind of immediately by that is our clothing closet. And so we have a very large clothing closet with shoes and boots and all kinds of other things. And we also, we do brisk business with Maine Needs.
Ben, we did have a question that popped in, and I'm wondering
Sure.
while you have your floor plan up. The question was, it would be helpful to understand what isolated by sight and sound means and why it is used for younger guests.
Sure. So if you look at this space, you could imagine maybe a young middle school student coming in that isn't as familiar with folks experiencing a psychotic episode. And that could be pretty scary for somebody. So those individual rooms allow for privacy. And then if it's somebody who's really experiencing a first-time crisis, a middle school student with some suicidal ideation, we may even serve them in the rest of the building rather than even in this area. At the same time, there are others that are very comfortable in that milieu. So we just want to make sure that folks are served in the place where they're most comfortable. Any other questions about that?
I think you hit on it.
Thank you. So we are able to provide crisis assessment and crisis prevention planning, de-escalation. We're able to serve folks really anyone below protective custody level of care. So if a person is in police custody, they need to be triaged through the emergency department before they come to us. That's actually Maine law. That said, we have law enforcement drop-offs on a regular basis for folks that are in voluntary custody. Provide short-term counseling, psychiatric evaluations, short-term case management while we hook people up with other services. We have the pharmacy on site. Folks that lose access to medication, maybe they've moved from one community to another and the prescriber is no longer going to continue prescribing. They're able to come in and see somebody that day while we transition their care to another provider. About 50% of the services we deliver are peer-related services. You don't need to have a crisis assessment when you come in. You can come in and just meet with somebody else with lived experience and then leave. There's not a specific way that you have to receive services through a crisis receiving center. I think it's one of the major benefits. I talk about it as choose your own adventure type services. We also are the statewide provider of telehealth weapons restriction assessments. So you may have heard about these recently. They're called Yellow Flag in Maine. And law enforcement across the state are able to reach one of our psychiatric nurse practitioners 24/7 for those weapons restriction assessments. At this point, I think we're around 78% of assessments statewide have been done by us. This is the unique guests served by month. It's a little bit of a confusing slide. We started in February of 22, and what you'll see here is the unique guests per month, not unique guests total. And so 206, for example, in January of 2023, there are possibly some of those folks that were also served in February of 23. So it's just the unique people seen in a month rather than across the entire period of time. I think there are about 1,200 people that have been seen over the entire time we've been open. That's just the individual month by month. When you look at the number of visits per guest and the number of visits total, you can see that, you know, it's about a little bit more, 2 visits per guest. So I think that's one of the most fascinating things for me about this service is that we are not seeing people come back again and again and again, that most people are able to resolve their crisis in a very short period of time. And we see a lot of folks that will come in and then end up going home knowing that they can come back at any time. They choose not to seek higher levels of care like a crisis residential because they know that the center is open 24/7. When you look at the total guests per month, that represents the number of individuals, a number of individuals coming in multiple times. There is a select group, about 13%, that come in very, very frequently. Those are often individuals that have co-occurring substance use disorders, serious mental illness, and homelessness. See a relatively even gender distribution. You also see a small percentage of individuals who identify as transgender accessing the space. There is a disproportionate, as you would expect, number of young people who are homeless and identify as transgender. So that is a disproportionate number of individuals accessing the space. You'd see a pretty standard age distribution of what you might expect. I think what is interesting, though, is about 14% of folks are qualify as transition age youth. And so a relatively high percentage of young adults. And you see those young adults, transition age youth, tend to skew towards the older end of the spectrum. You see over half of individuals are able to resolve their crisis in 1 to 2 visits. That goes up to 77% in 3 to 5. And then you see a very small percentage of folks kind of at the end who require many, many, many visits. This is some of our evaluation data that we've done with the state. 100% of the people that are brought in by law enforcement are received within 10 minutes. In reality, pretty much everybody that comes in is seen immediately. You're greeted when you walk in. There is no waiting. You're just able to walk through the door. 97% of individuals who receive services do not need hospitalization. And so the vast majority of individuals that we see do not require higher levels of care. I think that's another strength of the service. And And about 3% of behavioral health calls in Maine and Portland by the Portland police are being diverted to the living room rather than the emergency department. And that number varies up and down depending on what's happening in our community at any given time. Less than 6% of folks require higher levels of care, including hospitalization and CSUs. And so again, it's a very efficient service. Most people are able to resolve their crisis within a short period of time. And then knowing that you can come back means that you don't need other types of care. Bree, did you have a thought?
Nope, you're doing great.
We take admits overnight from the hospitals anytime, but routinely from Maine Med and Mercy, but also from Southern Maine and Mid-Coast. We've had occasionally folks come down from CMMC and St. Mary's. We routinely receive drop-offs from Portland and South Portland, Westbrook and Scarborough, and occasionally from outlying departments, but we work hand in hand with law enforcement to try and divert folks both from the emergency room and from jail. This is a colorful slide. It's an interesting one. It's who's providing the service when you come in. And you see really there are two major groups that are providing the bulk of the service. Those are certified intentional peer support specialists and then crisis service providers. And so over 50% of the services are delivered by peers at any given time. Then what you see are really a healthy amount of service delivered by nurses. That's often related to wound care or underlying health conditions. And then a small amount that's delivered by the nurse practitioners, but it's that service that allows folks to not need higher levels of care a lot of the time. So having an on-site pharmacy and somebody who can prescribe medication on-site makes a huge difference. Again, all services are voluntary, so there's never forced medication or medication over objection. We don't do restraints. People can come and go as they please. This is a 100% voluntary service.
Ben, we had another question come in, and since we're talking about the staffing and availability of services, the question is the living room, can folks walk into the living room to receive peer support services 24/7? But if
Yes.
someone is looking for clinical support or wound care, would that be during only the hours of 9 to 5 p.m.?
Yeah, that's a great question. So clinicians and nurses are 7 to 7, 7 days a week. And so there should be nursing on site for wound care in particular during those hours. And I would say that that wound care is really triage and then patching you up and getting you to the right place. And so that could be to a primary care provider. In some cases, we have folks that do need to be transported to the hospital related to infections, things of that nature. We do a lot of work with the Learning Collaborative in Portland as well. So it's really tertiary care, triage, and getting you to a higher level of care a lot of the time. Peer support 24/7. Clinical support 7 to 7. Crisis service providers 24/7. Any other questions about that?
Yep, we'll let you continue on. Thanks.
Thanks. So when you look at the, look at our customer service results, most people say they were served in a timely manner, that they were treated with respect and kindness, were hooked up with the services that they need. And we need to do a little bit better on making sure that everybody has a plan that they can hold when they're leaving the center. We've talked a lot about that. I'm a big believer in having something that you can refer back to. I also know that when you give somebody a piece of paper, it often ends up in the trash. So we want to make sure that we're providing follow-up care for folks in the way that they want it. This is my contact information. We are always happy to tour people through the space. If you have any questions, please feel free to follow up with me. We're happy to talk about the model and the services. And I think the rest of the time is slated for question and answer.
Questions and answers. So, Ben, I think as I'm looking through some of the questions coming in, they seem very much specific to programming and not necessarily state perspective. So I will read through them and then give you an opportunity to chime in. Are most guests from the Portland area, or do you get folks from other areas of Maine?
So we see folks from all over. We've had folks that have driven down from Bangor. So we serve all of Cumberland County. Of course, Portland is the most populous part of Cumberland County. So a lot of folks are coming from the Portland area, but there's no restriction. We don't say you can't come here because you're not from Cumberland County.
Great. There's another question that came in related to, is there an option for transportation to the living room?
So we can't go pick people up. That said, folks are often transported to us in different ways. So we have people that come to us via law enforcement. We have folks, the hospitals will transport to us with their shuttle service or with cab passes. There are times when mobile crisis or another behavioral health provider might transport to us, but we can't go get somebody. We also can't receive folks via ambulance. That's another Maine law issue. We'd love to be able to do that. We do transport people to other places. So there are times when somebody might get into a crisis residential or into the homeless service center or want to go to the Portland Recovery Center. All of those we can transport to.
There is another question here related to the low numbers of repeat visits and the assumption that the crisis has been resolved. Is there evaluative outreach and follow-up efforts that support this?
That's a great question. There is some follow-up, but there is not a ton of follow-up. And the assumption that the crisis is resolved is really based on the fact that we see people coming in if they need more help versus folks that may come back a month later or 2 months later or stop in just to say hi. One of the most interesting parts of this for me has been the difference between actual support and perceived support. And so I see the sign outs every night. And what you'll see frequently is somebody that's come in for a crisis and offered an overnight and said, you know what, I think I'm going to go home and I'll come back if I need. And that is a very common experience. And it's kind of the opposite of how other behavioral services have worked. We've really operated from a scarcity mentality that you have to wait on a wait list for a very long period of time. And then when you get a service, you're never going to give it up because you're never going to get it back again. So this has been a wonderful change to the system.
Great. We have a few other questions related to max capacity of the center and how frequently are you operating at max capacity?
So max capacity is a moving target. We've got the 8 rooms, and then we've got the central space, which can hold 3, 6, 10 in general. We've never turned anybody away. And so that's really been one of the special things about the service too, is that you can have somebody that their crisis is resolved and we can say, hey, would you mind hanging out in the central area where we give somebody else a room? And most of the time folks are absolutely 100% okay with that. That allows us to flex as we need to make sure that we're able to fit anybody in. So I hope we don't hit a max. I was terrified of that when we started, and it's been something that's been really different.
Great. Another question came in regards to a comment you made about what did you mean on the slide that peer time is not billable under statute?
Did I say that wasn't billable under statute? So peer time is billed currently as part of ACT and BHH and OHH. It is not billable under 65 crisis. Now this is changing. This is a wonderful thing. I know Bria's worked hard on this. So there isn't a way for us to bill Section 65 services, crisis resolution services for peers. And so right now that part is funded via OBH. So they have supported us in expanding access to peer services within the crisis continuum.
Yes. So all of the services that are operated, as Ben mentioned, those that do not have a reimbursement mechanism through Maine Care Services and or for others that do not have Maine Care, the services are covered by us. That would include some of the nursing supports, peer support services. And so it just allows us to kind of blend resources to fully make sure that everyone can access all of the services based on their individual needs. So it's been working
Oh, you know
well.
what? That's the state slide that has the ones in red.
Yes. How difficult has it been to recruit and retain staff?
You know, I think all behavioral health providers right now are having difficulty recruiting and retaining staff. This is a pretty fun model. It's a very rewarding model. It's a team-based model. And so I think we've had better luck retaining folks than other services or other programs that I oversee. I think that we have struggled in some ways to recruit nurses. There is certainly some stigma related to behavioral health nursing, and we still don't have overnight nurses. That said, I think that's something that we've learned we might not need as long as we've got on-call support. So that's active discussion with the state. But we've been pretty lucky in that area. I saw a question just to add, do I know the law issue for ambulance? If somebody's picked up by an ambulance, by law right now, they have to be transported to the hospital, and that's in a bunch of different areas. Part of it is where the person is allowed to be received, and the other is where you can bill from. So that's deep into insurance regulations. It's not something that I can speak to very easily.
Great. So we have a few more questions here. What is the protocol for people that show up to the center who are under the influence?
So our kind of standard is that a person has to be able to ambulate. If you're being carried in, at that point, you really need to be seen at the ED before you come to us. But it's relatively common for folks to come to us to metabolize. It's also okay for folks to come to us post overdose. We see that pretty frequently.
Great. I see another question coming in regards to the funding, and the question is this grant or ARPA funded? This currently is mental health general funded in support of the department and Maine Care reimbursable for the parts that are billable. Let's see, I'm scrolling through. You guys are bringing in some really great questions into.
One about search and seizure process and if we had any major problems. I would say that we've had fewer security issues than one might expect. We have certainly had instances where law enforcement has been called, but it's pretty few and far between. I would say that the design of the space, the way people are greeted and treated, and the voluntary nature of the space means that most of the time we don't have big problems. I think there are times when we might have somebody that uses in the space or uses in the bathroom, and our general response, if they're safe, is to say, why don't you come back tomorrow? And so that's our general response when there's something that is problematic. We encourage people to try again. Any feedback on the shortage of night nurses? There's a nursing shortage in Maine. My wife is a nurse and has worked to hire nurses as well, so we're in competition. I just think everybody's having a hard time with it.
I have another question here about, can folks immediately access medical assisted recovery, specifically Suboxone?
Well, immediately in the sense that you can meet with a nurse practitioner and the nurse practitioner can prescribe, but we're not quite at the point where we can just hand it out yet, but hopefully someday we'll be able to do that.
Great. The next question is an exciting one for us to answer. Is there other agencies or initiatives to expand this model throughout the state? And so, as many of you guys may have seen within some of our current legislation and from Governor Mills' commitment to establish a plan to plan and expand the next center within the Lewiston region. So we do anticipate to continue expansion. Obviously, there's a lot of planning that goes into that and resource gathering. And so I think more news to come, but we do anticipate the next one in Lewiston, Auburn. Okay. Let's see. This is a really great question here, and Ben and I continue to work with our hospital partners and other finance folks, but it says, has there been any analysis on benefits of greater community, such as saving money for not going to the hospital? That is kind of phase 2 of some of the financial kind of data that we'll be reviewing and looking at to see cost savings, to really see about the model. Right now, we have not gotten that far, but that is a plan within our phase 2 of evaluations. I don't know if there's more to say on that one.
Yeah, that is a very hard thing to measure. And I'll tell you a couple of ways. So one is you can't measure something that hasn't happened. And so you need to look at maybe other communities or other ways of getting at the same thing. You can do a pre-post. So if you've come to us and not gone to the hospital, there's no hospital visit that you can compare it to. So you can say, did you visit the hospital before you came to us a number of times? And then once you started coming here, you can't. So one example is we have somebody that overdosed in the community. I think it was 11 or 17 times in the year before we opened. And then they didn't overdose in the community at all after we opened. And so there are ways that we can look at it that way, kind of time series design stuff, but it's a very tricky number. What we do know is that it's less expensive to be seen at a living room or at a receiving center than at the hospital. And so we know that there are cost savings there.
Okay, so there's another question here, and I'll kind of kick us off, Ben, and turn it over for you, since you also are a CCBHC site. Does the service have a relationship or a way to interact with certified community behavioral health clinics in Maine? And so as we talked about a plan to plan for expansion, we're also in our planning phase of our current CCBHC design. I think that part of the plan and what we've seen nationally is a lot of states have utilized a CCBHC model to be part of the allowable activities within. Currently, right now, we're still early in our implementation and statewide access to receiving centers. And so there's definitely partnership, but they're not fully integrated into the payment model just yet. And so Ben, as a CCBHC, maybe you could speak a little to how you see both efforts kind of working hand in hand.
Absolutely. What I would say is, and Bree, I hope it's okay to share some of the conversation that we've had with the state, is that they are really working towards a both and model. So I see crisis receiving centers as integral to CCBHCs. So Spurwink has a CCBHC. If you're coming in for assessment, just a basic assessment and services, you can go to one door. And if you're in crisis, you can go to another. And so there's a lot of work back and forth. I think that there's also a need for receiving centers in areas of the state that that might not have a CCBHC. And so if we were to say it's only part of one, then we might not be able to do it in other areas. So I appreciate that the state is trying to do both at the same time and make sure that there is robust access to receiving center support, both within CCBHCs and in other communities.
And we had a question here. We didn't mention where the center was located.
62 Elm Street, downtown Portland. Come on by for coffee. No assessment needed.
Okay, let's see.
We use Fred's coffee service. It's not the bottom tier coffee. It's better than Folgers.
So we have a few questions here in regards to, do you have the ability to manage those in withdrawal of benzos or alcohol in non-business hours? This has been a barrier at other social model types of facilities.
Up to a point, and it depends on the person, and it's an area that we want to expand. So both alcohol and benzo withdrawal can be deadly. And so we are very interested in expanding our ability to provide ambulatory alcohol withdrawal. We also need to have very close coordination with medical providers that would allow for an immediate admission if somebody deteriorated in a way that we couldn't manage in the space. I think the last number that I heard was that there's one withdrawal bed for every 5,000 people in need in the state of Maine. And so being able to coordinate with medical providers, with other facilities to expand access is going to be a kind of ongoing and major initiative for us. We've talked with Milestone and Mercy about it. I think we're looking at other partners as well. So there's limited ability, just simply based on the medical risk, but it's something that we want to do more.
The next question is for individuals who are unstably housed or housing as part of their crisis. Do you participate or plan to in the coordinated entry referral system and the homeless hub system?
So right now we are not part of coordinated entry. We're not a coordinated entry site. We have considered becoming a coordinated entry site. It's an additional layer of administrative work that is completely separate from the additional behavioral health work that we do. And so there's some nuances to that. That said, we work very closely with the Homeless Service Center and our local other homeless service providers.
Okay, I'm going through. I think we're touching on many of the questions. They're slowly trickling in. So if you have some, I know there's some are coming in through the chat and some are kind of shifted over to the Q&A tab. And some folks are really liking the model and asking if you have considered applying for the Kennebec County Crisis Receiving Center and Detox RFP.
The Kennebec County is a very different model. And it involves inpatient withdrawal facilities. That's something that Spurwink doesn't currently offer. So we have not considered applying for that particular proposal. I think as the state looks to expand this model, we probably would be interested in expanding living room services or crisis receiving center services. I see another question about algorithm for determining risk and yellow flag assessments. That's statutory. And so It's whether somebody poses a likelihood of foreseeable harm. You can look it up under Title 34B. And so it's whether a person is a mentally ill person who poses a likelihood of serious harm. And a mentally ill person is not a diagnosis, it's a collection of behaviors, is a better way to think about it. So if you look at those two things, it'll give you the algorithm.
Another question that has come up is, does the crisis evaluation you do at the living room differ from the crisis evaluation done by mobile crisis agencies?
Say that again?
Does the crisis evaluation you do at the living room differ from the crisis evaluation done by a mobile crisis agency?
It needs to meet the same standards.
Yes.
So each mobile crisis provider has a slightly different form. Ours looks slightly different. But one of the really nice things is that, say, our crisis assessment can be used for access to Broadway crossings from TOA. And so there's a lot of work kind of back and forth among all of the different crisis providers.
I think that's a really important part in regards to, as we're trying to really think about those warm handoffs between crisis services that are available across the continuum, and really having that similar assessment allows for a lot of the sharing of information without that needing to reduplicate and or re-traumatize individuals while they're in crisis. And so it is aligned as they both services are reimbursed through that crisis assessment mechanism under Section 65 policy.
See a question about follow-up after yellow flag. So we provide a very discrete part of the process. So the first step in a weapons restriction is that a person is placed in protective custody by law enforcement. Law enforcement then arranges for an assessment. We conduct the assessment, and then really our part is done. After that, law enforcement brings it to the district attorney, and there's this kind of multi-step process that happens after the initial restriction. There's follow-up by both the district attorney and law enforcement that allows for the possibility of an extended restriction.
And another question in regards to the expansion. Yes, the department is looking in regards to, as part of our planning and financing strategy, to continue to advance similar models across the state. Is the hope is that we would be able to be further up north again, and making these centers very community specific.
I see a question from Courtney about other policy and law issues that need to shift.
Yes.
Tons of them. Probably outside the scope. In terms of withdrawal management, detox, again, there was a question about would they be referred elsewhere, or would we be able to provide services? That is very dependent on the substance and the level of need. So we work closely with local detox facilities. There are some things we're able to handle, and then there are some things that need to be referred out to. And there are times when somebody needs to go to the hospital. We've certainly had folks that for a complicated alcohol withdrawal, inpatient is the only way to go.
Okay.
I see David asking for my contact information again.
Yeah, maybe dropping that in the chat would be helpful for folks since the slide's not up.
I will do that.
And then again, just going on, as we continue to advance the model, we want the model to be responsive to community needs. And so within that, we would take into account geographic challenges and work with telehealth. Currently now, even with the model that we have in Cumberland County, there is oftentimes that there is telehealth support offered in those hours and on-call supports in the evening hours at the current center. And so I do anticipate continuing obviously in person and having a place to go is ideal, but we do understand some of the limitations with those staffing needs, and that some of that work does happen via telehealth.
I think it's also important to differentiate between telehealth follow-up and um, and the main crisis line. So we are very clear that we are not the main crisis line. It's a different part of the system. It's an important part of the system. And so we work with folks to access the main crisis line if that's what they're looking for.
We have a question here in regards to, in terms of young people under the age of 18 who consent for a crisis assessment, do legal guardians need to be contacted?
Depends, I believe, on whether they are an unattached minor and the circumstances. So it's case by case.
Great. Let's see. Kind of going through.
I see one from Dr. Vinsel about cost efficiency of the crisis receiving center. I was just discussing this. I believe an ED visit is in the $1,600 range. Is that correct, Bree?
Correctly.
Yeah. So we're about $800 per person per day.
Again, and I do think a lot of the financial review and kind of looking at the program and looking at kind of a daily rate, I think that goes back to the comment earlier about kind of a both and approach, like really looking at being able to wrap this model into potentially different reimbursement mechanisms. So if we had a standalone approach, really looking at what, you know, that mechanism would be from a main care reimbursement versus also having the ability to wrap into, when ready, into a CCBHC payment structure. And so again, these are all elements that we're exploring and looking into and doing some formal planning for in regards to how we'd be able to continue to maximize expansion efforts.
So I see a question about reduction in ED visits. I don't have Maine Health or Mercy ED visit data. What I can say is anecdotally, they have told us that there's been a decrease. What we have also seen is a lot of folks that will be seen at the ED that may not be appropriate for hospitalization or ongoing care, and then they are immediately transferred to us. So there's both folks that come to us instead of the ED, and then people that are quickly transferred from the ED to us.
I think that's really important within the model and building those relationships between the centers and the hospitals that allows folks to get that very, you know, medical clearance. You don't need to be here longer than you need to be, and really getting you back into a community least restrictive setting. And so it's really great, Ben, in regards to the partnerships that you have with the hospitals that are local to you, that those warm handoffs are happening and very effective within getting folks to the appropriate level of care. And that's not always hospital setting.
Yeah. I see a question about Sublocade. We do that.
Okay, if you're looking at them, keep feeling free to read them out, and I'll clear them out as we answer them. That one we did around expansion. So, okay, done. I'm looking at the other chat box if we've hit anything. Many of you guys are highlighting this is clearly a hot topic right now in legislation. There's a variety of bills currently out for folks, you know, really wanting to see expansion of such a model. And so a lot of opportunity for you all to contribute and participate in whatever feels most comfortable for you.
I see a question. Do you have these connections established with EVS? Do you mean emergency departments? I would just look for clarification on that question. Yes. So our connections currently, we We do brisk business with Mercy and Maine Med. We have been doing increasing business with Southern Maine Health. We do a fair amount with Midcoast and a limited amount with St. Mary's and CMMC. But I would say that, there's a lot of back and forth with Maine Med and Mercy.
I think we've also seen some great natural kind of partnerships for individuals that might be residing in a mental health residential type program that are also able to utilize the center if versus going to an ED visit. And so we have had folks that have, said, I'm going to head to the center, which is a lovely option. And then obviously able to make coordination and, support back to get individuals back in. And so we are seeing some partnerships there with the residential programs in the community as well.
Yeah, do a lot of outreach there. And when I see other electronic referrals, I think one of the things about referrals to EDs, you got to remember that most people stay with us. So we're trying to send very, very few people to the ED, and really it's anybody below protective custody level of care. And so as long as you are not a true danger to yourself or others, we're going to be able to manage it. Or if there is a serious physical health risk, we're going to be able to manage it. So we're not sending many people to the hospital, but we're taking a lot of people from the hospital. And we ask that you call us first. That would be the only requirement. Let us know they're coming, and then send us the discharge paperwork. Ellen clarified from the ED. We often get faxed or emailed the discharge paperwork. Oh, I see a question in the chat. David, I did put my contact info in. I don't know if it worked. Let me see if I can try it again.
Ben, you sent it to me. So I just bumped it back in there for him with your email address.
Thank you.
And I will add your phone to that as well. It
Thank you.
Came into your co-presenter. Okay. There you go. Okay. That one we have done. I keep trying to go back and forth between these two. Okay. Well, we're just about at 12:30. I apologize if we did not get to your specific question. I know within these seminars, those questions that are unanswered often do get a formal response after the fact. And so I greatly appreciate the time today. And thank you, Ben, for all of the great work and really kind of bringing this new model to life and really enhancing our places to go within our crisis continuum. And so I just want to thank you and your team. Your team has worked incredibly hard to get this up and off the ground. So thank you so much.
Thank you so much. I would say this is absolutely one of the most exciting programs that I've had the opportunity